Good evening, colleagues. Thank you once more for joining us this evening for this session brought to you by FIND in support of the National Department of Health. I welcome you again. I'm the moderator of the webinar. My name is Dr. Ausing Godana, a GP based in Pretoria in Gauteng, and I have a huge passion for cervical cancer prevention. I'm here today in my capacity as a consultant, or what you would call a technical advisor, working with FIND. And as I've said, I will be moderating this webinar. This, colleagues, is the last in our series of webinars that we started hosting about 2 months ago. So please enjoy this last one. We will meet again. So if you are asking yourself, and maybe you are joining us for the first time and you are wondering who is FIND, FIND stands for the Foundation for Innovative and New Diagnostics, and is a global nonprofit that is focused on advancing diagnostic innovation and improving access to affordable and reliable diagnostic services, especially geared towards women and girls in low and middle income countries at the primary care level and within communities. So, colleagues, we know by now why we've been engaged in this series of webinars. We know that cervical cancer is the 4th commonest cause of cancer globally, and it is the most common cause of cancer in women in Africa, where it accounts for 22% of all female cancers. So, colleagues, our work as FIND in South Africa is to support the national and provincial departments of health. We work with the private sector and research institutions to expand cervical cancer diagnostics nationwide. We also support the National Department of Health's Mother-Daughter campaign, which is aimed at strengthening and expanding the HPV vaccination program to ensure that 90% of girls between the ages of 9 and 15 are vaccinated. Also, the campaign aims to introduce HPV screening to reach 70% of eligible women. In addition, the campaign is geared towards improving treatment and linkage to care, thereby reaching 90% of women with precancerous lesions and linking 90% of women diagnosed with invasive cervical cancer to the next level of care for surgical, chemo, and radiation therapy. Colleagues, the campaign also aims to develop an electronic data management system to record individual level vaccination data and to track and monitor the vaccination program's future impact. So, colleagues, this is what we have been doing as FIND and what we continue to do in support of the Department of Health and also working with other stakeholders. Let's get back to today's workshop. Before we go into details and before I introduce our speaker, let me clear some housekeeping rules or some housekeeping issues, and also reassure you about where you will find all the material that we have gathered over the last couple of weeks. Firstly, in terms of housekeeping issues, myself and the speaker will be able to unmute during the presentations, but colleagues, you won't be able to unmute. But at the end of the session, we will open up for questions, and if the environment allows, we will be able to unmute you. So, colleagues, if you do have questions as we proceed, as the professor is presenting, please post them in the Q&A section or on this platform so that we can keep track of them. We will answer the questions at the end of the session. And before we log off today, colleagues, this being our last day, please remember to complete the evaluation and give us your feedback in terms of how you found the series and what we could do to improve on the work that we have started. Also, colleagues, you'll be pleased to know that we will be sending you a link to all the recordings everyone who has ever registered for these webinars, the last 7 webinars. Next week, you will all be sent the link to all the recordings. So colleagues, that one is settled. Everyone will get it through their email. Also, just a reminder, colleagues, that the webinar is accredited for 2 CPD points, which will be submitted directly to the Health Professions Council. Give us a month to get all this admin done, but you will receive your CPD points. So that is on the housekeeping front. Let's get into the presentation of today. Colleagues, it gives me immense pleasure, and really we are very privileged to be joined today by Professor Motsidisi Sebitloane, who is going to take us through the cervical cancer screening algorithms and the rationale behind these algorithms. She will also share with us some of the findings from the much talked about CESTA study. She will tell you more about it during the presentation. Colleagues, Prof. Sidi is an associate professor and head of the academic and clinical department of ONG at UKZN. She is a member of SASOC and has served 2 terms as a member. She's also a member of the College of Obstetrics and Gynecology and is currently the Secretary of Council and previous chair of Part 2 of 2 committees. She has served 2 terms in FIGO, in the FIGO Ethics Committee. Colleagues, those who are involved in ONG, you know what about the FIGO classification. So Prof is involved in the Ethics Committee. She has also served as a consultant in the WHO Guideline Development Group for management of pre-malignant lesions of the cervix. So colleagues, these algorithms we'll be talking about, she has been heavily involved with them, and please ask her as many questions, clarify as much as you can. She also has served as a principal investigator for a WHO IARC-sponsored study to test out the algorithms, and that is in the CESTA study that I was referring to. She's currently a member of the HIV Clinician Society and ACTG Trial Networks. She holds a PhD on maternal health and HIV and has mentored more than 20 MMeds and 3 PhDs and is widely published. She has 40+ publications under her belt. Colleagues, please join me in welcoming Prof. Sidi Sebitloane. Prof. Sidi, we are honored to have you with us. I hand over to you. Thank you so much for coming through.
Yeah, thank you so much, Dr. Nti, OCS, we call her. Thank you so much for the wonderful work you are doing for this organization. And I think for us as a country, as we are gearing up towards the 90-70-90 targets of cervical cancer, those of you that have been following WHO, you'll remember that the United Nations and WHO launched this strategy to eliminate cervical cancer by the year 2030, in that targets of 90-70-90 that Dr. Nti has alluded to. And thanks to everyone for joining us tonight. She's requested us to go through the updated algorithms, which at this point are very fluid and nothing cast in stone. So as of last year, the Department of Health National released a circular to say that we're all moving towards HPV screening. You know that our screening since 2014 has been, well, free for women, but it's been cytology-based. And then of 2018, WHO said all the countries that could do it should try and migrate towards the HPV screening. And so those algorithms that she spoke about were released in 2019. So as a country, we also embarked on a pilot in 2022, and I'll share some of the details of that pilot of trying to see how feasible is it for us to move towards HPV screening as a country. There were some guidelines also released by the HPV board that is a board that exists in the country under SASOC. Those of you that are in the organization will know what is SASOC. So there are various guidelines that have been released. And therefore we have to look at each one in its own merit and why we are where we are as a country, and even given the liberty to formulate our own guidelines as provinces in the country. So without much ado, I'm just gonna move. That's the slide that you have right now. Also, do we have, can we call, I'm pressing move, but okay. Am I on slide share? I think I am.
Yes, you are, Prof.
Okay, I'm trying to move forward.
Yeah.
It's not allowing me. Let's see.
It's not allowing you. If you go enter.
Yeah, I do enter, not moving. I do next, not moving.
Okay.
Okay, let's start new share.
Yeah, maybe let's restart again. Okay, all right. My colleague Lamia is just as suggesting that you reshare again, stop sharing and start again.
Let's slide. Okay, colleagues, bear with us. Technology always does its own thing.
We can try it again, Prof. If not, then we'll ask Lamia maybe to assist us with the sharing, because you do have a copy.
Okay, I'll start again.
So stop. Have you stopped the presentation, Prof? Stop it right at the bottom of your screen.
I'm not sure where it's failing me. We have the.
Okay. All right. I'm going to also type. Yes, you have unshared, Prof. Yes. So try sharing again.
Okay, I'm there now.
Yes.
Is it moving?
We can see it. Not moving still.
Yeah.
We are still on slide 1.
Yeah, it's not. Maybe let me exit 100% and do side by side.
Okay. All right. I'll also try and see if I can share on my side. Let me be ready for that. Try it again, Prof. Then if it doesn't, then I'll share from this end.
You can see it again.
Okay, let's see. Yes, we can see it. Can you move?
None.
Still not moving.
Yeah.
Okay. All right, Prof. Let me try and share from my end. Let me see.
Apologies, colleagues.
Yeah. When we were trying it, it worked very well. Now it's not working.
We did have a trial run, which was successful.
Apologies, colleagues. I'm trying to see if I can share it on my end. Prof, you sent it from which email? I'm just trying to find it.
To your one, the one that says OC. I sent it to them.
Your email address.
Which one I am?
It's Prof, your email address?
Sebitloane M. Can somebody say what they are seeing right now? I'm on slide 2. Are you able to see that?
Okay, let me come back.
Maybe
Yes, we can. We
okay.
can.
But
then
from the slide, I want to.
It's not on.
Yeah, it's not on slide share.
Yeah, or not on slideshow.
Yes.
Okay, so okay, continue, Prof. Continue while we try and sort it out. Let's continue in the meantime. Okay. Yes.
Okay, I think we move it.
Yes.
Okay. So basically that was the outline. Yeah, so I think as a background, we all are aware that cervical cancer is a preventable disease, and hence why the efforts for us to prevent it, and we should make our efforts to do that. It's the fourth commonest cancer among women, and we know that in South Africa is the leading cause of women death among the cancer. Move this away. So, and we know that it has a causative agent, which is mainly HPV, 16 and 18. And I know that there's quite a bit of variation in terms of our understanding as to why certain high-risk types are appearing when we screen, whereas when we talk about cancer, it's mainly 16 and 18. So some of those are confusion things we will try and clarify along the way. So 16 and 18 are the ones that are mainly responsible for the cancer. But when you look at pre-malignant lesions, there are other subtypes that are appearing, and those would be 31, 33, 35, and 45, and sometimes 52 and 58. Just so that we understand that it depends at what you are looking at. If you're looking at cancer, you took it 16, 18, but when you're looking at pre-malignant lesions, you're looking at other high-risk types. They go in various proportions. So once again, when it comes to the infection itself, again, somebody asked the question that we are having an epidemic of HPV infection. It is not necessarily so. So what we are seeing now is that because we are testing, we are able to tell what are the higher subtypes, what is the prevalence, and therefore what is the burden of these infections that we have. But HPV infection per se is just a marker of sexual activity. So when you look at people who are having sex, the large proportion of them will be having some type of HPV at one point or another in their life. So when you look at the slide here, looking at the 15-year-olds, which is the young people having sex, a large proportion of these people, if you test them at any point in time, you'll find that they have the HPV of some sort at their age. And these infections are supposed to clear within a period of about a year and towards the end. So most people are supposed to be able to clear these infections. There will be reinfection over time, but they are not supposed to persist long. So when you're looking at where you are testing, if you're testing for HPV at 15, you are likely to find a large number of these women being carriers or being infected at that point. If you're looking for pre-cancer, the second arrow, you'll find that you should be looking at about age of 30, because it is said that this persistence, which depends on the immune system, on other things, takes about 5 to 10 years for it to develop and be integrated into the cell, for it to form pre-malignant lesions. And that's the second area. And now we're looking at cancer, the peak is around 45 years, and that's where we should be. So all of this, if you understand this graph, you'll be able to see why we do not do HPV testing before the age of 25. Because if you're going to test all 25-year-olds and younger, you are likely to pick up a lot of infections it doesn't tell you anything. So if you are looking really for a disease you can prevent, you should be looking around the age of 30. Hence our old cytology policy that said we start at 30, 40, and 50, because there you are looking now for pre-cervical disease, malignant disease, and that's the one we want to treat, that's the one we want to prevent. If you're looking for cancer, we should, as we said, our guidelines at 30, 40, 50. So I think this graph just puts it nicely for you to understand why we test at certain points and what we should be testing for at those points. So there's a number of, it's said that there's more than 150 subtypes of HPV. Some of these are cutaneous, others are mucosal. You will remember that we've got the vulval warts, which are 6 and 11, those are low risk. Then we've got the high risk subtypes. And amongst these, there's about 14 to 16 that have been identified. But the leading ones when it comes to cancer, as I mentioned, is the 16 and 18. In these, the different groups, the group A, the group Bs, again, depending on what you're looking at in terms of their ability, their carcinogenic ability. About 16 to 8, 14 to 16 of these high-risk subtypes. This slide again just goes back in terms of what should be happening to people who are infected with HPV, the higher prevalence being amongst the younger women, expecting that most people should hear it. And as you go across, you should not be having HPV. Now this, when you have a high, when you have HPV infectivity and the ability now to have normal cells, that's why we are saying we shouldn't really be focusing on screening the younger women, because you can have a high prevalence of HPV, but with normal cytology. And the ones that develop abnormal cytology is as the age is progressing. 16 and 18, again, when you look at the prevalence of abnormal cytology, so you get 16 and 18 as the lesion progresses. So amongst women with normal cytology, that would be about just a small fraction of 3.2%, but the lesions as they progress, low-grade lesion, 20%, 30%. And now, as we said, you find the 16 and 18 amongst the cancers, which is 64%. Saying the same thing again, the higher the lesion, the more likely you are to pick up these abnormal HPV or the highest HPV subtypes. And in a meta-analysis of this cross-sectional study, the distribution all over the world, they found amongst this large group of cohorts that was tested, that the HPV prevalence increases as the lesion goes up. So being lower with the normal cells and increasing with CIN1 or CIN2 as well as CIN3. Just move this aside. This again, just to re-emphasize that it depends where you are looking. If you're looking at your first slide here, on your left, top left, you'll find that 16 and 18, again, not featuring, because now here you're looking at your normal cytology. But you are beginning to see the 35s, the 58s, the 45s. If you go into your left bottom, which is your low cell, you are seeing now the 52s, the 35s, and the other subvariants. When you look at your top right, which is your high cell, 16 again beginning to show that that's the most carcinogenic one, then getting your 35s and 52s. So basically it just depends on, are you moving from normal cytology towards cancer? And there's no question about the carcinogenic effect of 16 that is showing in your cancer, which is your right bottom, 16 and 18, and then seeing your 35s, 33, and 45. So yeah, all these subtypes depending on which the abnormality that one is finding. So when you look at South Africa in particular, our topmost remain again 16, 18. Again, looking at whether it's the abnormal cells, high-grade cell, or it is the cervical cancer itself. Our leading subtypes being 16, 35, 16, 18, 35, 33, and 45, as well as 52, as shown in that graph. I just want to get rid of this. I'm not showing whether it's showing on your side because we are not on slide share. And then what happened? Okay, yeah, this slide continues just to show us really the subtype that we're dealing with. Now, this was a meta-analysis of studies all over the world and recently released in the Lancet. You can see here in Africa, again, just showing the subtypes 16, 18, again, going back to your 33s, your 31s, and the 58 as the predominant subtypes. And the very ones that are now included in the new vaccine that now has 9 subtypes. Okay. My slides do get frozen. Can we move on? Next one. Not sure what happens to. Okay, next slide. Be able to move?
You are sharing from your side, Prof.
Yeah.
To come out of the slide presentation.
Yeah, it's not showing perfectly. I'm not sure what is happening here. Pause the share, start again. Yeah, so where are we now?
We are seeing you, Prof. I'm struggling to find your presentation here. Please try and share again.
What are you seeing now?
Yes, we are back at the presentation.
Yeah, but it was moving. That was the challenge.
And if it's out of slide presentation, still not. Okay. If not, okay. So, Prof, let me. I've got the presentation. If you still cannot move,
yeah, maybe you do the sharing. I'll move with the slide.
Okay. All right. All right. I'm going to just close a couple of the 1,002 things that are on my screen, and then right. Okay.
Pardon us.
Okay. Let me see, Prof, where we are. Can you stop sharing? Then I'll take over the sharing.
Okay.
All right. Let me. Okay. Can you see my screen, Prof?
Yes. So we can go back to that slide we were at.
Okay. All right.
Yeah, we were here. Next one. Yeah, so in terms of the guidelines, as we were talking about, so we know that we've been screening from the age of 30. The government was putting people, women, 3 years, 10 years apart, provided all of these are normal. Obviously, if any of those are normal, you would follow a certain algorithm. And according to those guidelines, one would be able to stop if a woman had had 3 normal smears and none of these have been abnormal. So you would be able to stop at the age of 50. In women living with HIV, the diagnosis, at the point of diagnosis, they are supposed to be screened at 3-yearly intervals, and for them, it continues lifelong. Again, not to forget that we can screen during pregnancy. In actual fact, we should see that as an opportunity for us to screen during pregnancy because women will present. There's no problem with either doing cytology or HPV as we are now moving towards, at least if they come before 20 weeks of gestation. Next slide. Screening should be afforded at any point, especially at those ages as we have alluded to. But for every other woman that presents in a gynae outpatient, many times we find that women are not within the 30 years or 40 years, and therefore you find people sending women back without screening. We should use every opportunity to screen, regardless of whether maybe you are 33, 35, as long as you've never had a smear or a screen before, we should use that as an opportunity to screen. So I just put that slide here to remind us that we should not be fixated into the ages, but anyone who qualifies should be afforded that smear because we're losing a lot of opportunities in that regard. So when we look at the types of screening that we can afford, cytology has been the backbone, as I said, since more than 10 years ago. And we've done well. We've got a good infrastructure in terms of cytology. The turnaround times have not always been so good, but otherwise we've done well. And I think in 2020, the government moved towards what is called liquid-based cytology or LBC. And I know that there's 1 or 2 provinces that are still lagging behind to implement that. But it's been found that actually LBC is got a better pickup rate, though detection ratios in some studies, they look the same, but it's less amenable to collection problems. And also the advantage of LBC is that you can do further testing on it. For example, if you now want to use HPV, you can use that. So we should really, in provinces that might be struggling to implement HPV, at the very least, we should be at cytology, liquid-based cytology, and not using the air spatula as we originally did. Next slide. Next, okay. Yeah, so then we're moving towards HPV testing, which has been validated in several studies, and I think is the buzzword for now. The reason being that we're moving beyond the pre-malignant lesions, because remember with cytology, you are picking up the pre-malignant lesions, whereas with the HPV, you are now looking actually at the causative agent. And here we're not testing all those 150 subtypes. We're looking only at the 14 to 16 high-risk types. And some of the algorithms batch them in terms of the high risk or just the high-risk type. So that's where we are now. We're looking at HPV testing. Next. There are countries that are still struggling. So just remembering that there's something called VIA, visual inspection under acetic acid. As we can see, it delineates nicely the area that is bright and pink. It picks up the acetic acid, and it's got a good sensitivity when you compare with pap smear or cytology. But the problem there is intra-observer variability. It may have less accuracy when it comes to picking up. And therefore, it cannot be always reproducible. Hence, it has never been for us a screening method. We moved straight into cytology. Next. Another method would be to use your iodine, which is a similar application to that of acetic acid. Unlike with acetic acid, where the abnormal cells take up the acetic acid, here with the iodine, it is the normal cells that take up the iodine and they look more blackish. The abnormal cells, which have no glycogen, they would not be able to, because they are rapidly reproducing or multiplying, they would then look mustard or yellowish. and that will be the area that is. So we can still use even iodine for us or acetic acid at the time of colposcopy, just to delineate where the lesion might be. Thanks. Next. Colposcopy for us is a triage or something that we use to guide our management, but in some areas it can be used for screening as well. Next. So just coming to the main topic of today, looking at the algorithms. This is the guideline from the WHO released in 2019, basically to look at the different, basically the WHO was saying that at the very least, every country must adopt some form of screening method and run with it. We should not say we can't do this, we can't do that. We should look at your availability, your infrastructure, your resources, and then be able to implement one of these algorithms that they have alluded to. We will not go through all of them, but we'll touch on a few of them. So with this one, which is algorithm 3, this is similar to our old policy where we started with cytology. And according to this algorithm, women with ASCAS and up were supposed to be sent directly to colposcopy. Obviously, if we were to implement this in its format, it would inundate our services, which do not exist in most of the areas with colposcopy. So we did not implement it as such. You remember that was our old policy. If we had ASCAS or low cell, which is CN1, women were then, we would repeat the cytology, and only if on 2 occasions, then you would be sent for colposcopy, plus or minus biopsy, plus or minus treatment, which at the time was left. So this is the old, this is one of the algorithms in the WHO guideline, which relies heavily on colposcopy, and we cannot really afford it in our system. So much so that actually KZN decided, even for the other algorithm in the older one, that we would bypass cytology, colposcopy, and based on cytological findings, we would afford it. So this is not good for us. Next one. In this algorithm, which is 5, is one of those that we are likely to be aligning ourselves with, obviously with a few refinements. So in this one, we are our entry point is HPV DNA testing. If a woman is negative, which is on your left, we rescreen them in about 5 to 10 years, depending on whether they are living with HIV. If living with HIV is 3 to 5 years, then we would rescreen. So you don't have HPV, which means you don't have the causative agent at this point. We will come back in about 3 to 5 years if you are living with HIV, 5 to 10 years if not, and you want to see whether or not you have now acquired HPV or not. Looking on your right, if you are HPV positive, you will notice throughout all the WHO algorithms, this word called triage or triage, whichever way you call it, will be featuring quite a lot. And here they want to triage with VIA. If you see that there's some cancerous cells, obviously we implement biopsy and treatment further. If on triage, women have got either anything that is pre-malignant, it could be CIN1 or CIN2 or 3. You want to know whether they are eligible for ablation. And again, they are not dictating what form of ablation, though now they favor thermal ablation. It could be cryoablation, but so far for the rest of this talk, just remember thermal ablation, and we'll focus a bit on that. So you want to know whether women are eligible for that. If not, obviously you will treat them with lead. If they are, then you will avail them to have thermal ablation. And that those would be people with ASCAS, ASH, as well as no, ASH would be treated with, like high cells. So it's basically CIN1 and as well as ASCAS. We have modified a bit of algorithm 5, and we'll come back to that. Next.
I don't know if it's just me, but I've lost volume. Is anyone hearing Prof? Lamia, can you hear her?
No, I don't hear anything.
Okay. She's gone off, but I
I think
think
it's
she
the
will,
internet because she froze, but she will come back.
yeah. Okay.
Can you hear me now?
Yes, Prof. Yes.
Okay. So where did you lose me?
As you were starting this algorithm.
All right. So I was saying
Yeah.
that in this, the difference between algorithm 5 that I showed you, 5 being where we triage with VIA. In algorithm 2, there's no triage, though both of them is application of acetic acid. And that's where the sister study, which as you mentioned in the intro, in the sister study, it was actually funded by the WHO because they wanted to test algorithm 2 as well as algorithm 5 to say, can you just apply acetic acid? Will you be able to actually see the abnormalities even with an untrained eye versus the triage where the nurses actually were trained to identify the abnormalities? So we are not going to be using this because we want people to be trained so that we minimize the risk of over-treatment. In this one here, where you just apply, you are likely to treating a lot of women, particularly if we delay with implementation of thermal ablation. We might over-treat with lead. Next slide. Can you hear me?
I can hear you, Prof. I think now it's my slides that, okay, it had jammed a bit.
Yeah, this presentation is a bit jinxed today. I'm not sure why, end of October. All right, yeah. So then is another one that also has an entry point of HPV DNA. Now here we are introducing triage as opposed to just moving directly. And again, it keeps on saying determine eligibility for ablative therapy. So eligibility here would mean that you are using VIA, as you can see on your right. And if the lesion is less than 75% and you can get to the topmost, meaning that you can see the upper margin of the transformation zone, those are women that you can, and they are not high cell. Those are women that are eligible for ablative therapy. So the HPV board that we mentioned was a subsidiary of SASOC, seemed to favor this algorithm, and maybe the next slide will explain it better. So you can see, maybe going backward, OC, previous slide. So if you look at algorithm 4 versus 2 that we saw earlier on, here you are triaging by subtype, as opposed to just saying that the woman is got high rates, has got high risk HPV. Here you're naming 16, 18, and next slide. And when it comes to the HPV board, not only are they looking at 16 and 18, they are also adding 45 in the mix. So the HPV board, which is a subsidiary under SASOC, favored that algorithm, which is algorithm 2, where we subgroup women in terms of what exactly are they having. Remember right now that when we test, all that the lab tells you is that a woman carries high risk HPV. If we are lucky, they will name it in terms of 16, 18, whatever, but we are not paying so much attention right now with the subtypes. We are just saying, yes, you've got one of the 14 or the 16 high risk, and therefore you qualify according to the algorithm. But according to this, they wanted to subdivide it. Are you 16 or 18? Then you would go directly to colposcopy. And if you are a woman who is above the age of 40 and HPV positive, then only you will get reflex cytology. the algorithm that we are likely to implement or has already been implemented in some provinces introduces cytology higher up. The minute the woman is HPV positive, the lab automatically will do reflex cytology for everybody, regardless of your age, your subtype, and so forth, which is what this HPV board was suggesting. So we did not, and we are likely as a country not to follow the HPV board guideline. Next. Then comes algorithm 7. You'll find that the numbers are not, I've not used the numbers according to what WHO has numbered them, simply because I wanted us to flow and be able to understand where exactly we are. So according to this, if you are HPV positive, then you will get cytology as your triage. And this is where we are likely to be. We are going to, in some provinces, it turns out that, you know, this will what is called dual testing, meaning that you are now testing with HPV and cytology. And therefore, some provinces are saying it's a bit too costly to actually do dual testing. But we find that in the committee or the group of people that were looking at the guidelines, that gave us more comfort to say we will not rush and treat women just on the basis of being HPV positive, but we will treat those that actually have cytological abnormalities. Hence, we are using cytology as a country as a triage method rather than VIA, because VIA will need a lot of training of the nurses, of all the health workers, by the way, not just the nurses and the doctors, but also we already have a well-functioning cytology system, cytologists in the lab. We've used cytology all the many years up till this far. So using cytology, which we already have, makes more sense for us to triage our services with cytology. So obviously now with the new algorithm, which I'll come back to, this one, according to WHO, the minute you are ASCAS or worse, you would go directly to colposcopy. Again, that will inundate the services of colposcopy, which do not exist in many centers. Hence, we are now going to, again, divide them further. Next slide. This algorithm 6 goes directly to colposcopy. Here we will end up with a lot of over-treatment. There is a study that was conducted in KZN, where some of you that are in KZN, you'll know that the colposcopy services are only in regional hospitals. But when it comes to labs, we have rolled it out even to the district hospitals. And when we looked at the results of that study, there was a bit of over-treatment just based on treating women on the basis of cytology. So the correct way would be to do a colposcopy, as this algorithm say, and only when your colposcopy confirms the finding of cytology, then you should be able to let a woman. So in KZN, we're letting them without colposcopy, and that's why in some areas there's up to 20%, 19 to 20% of over treatment. LET is a very good procedure, by the way. It's just that it tends to overtreat, as we said, which is not a problem, especially in our setting where you may lose a woman to follow up. But remember that now that we're using HPV, and I said to you, a number of our young girls are likely to have HPV positivity, we are then likely to then treat them with, if we treat them with less, we are likely to overtreat them, end up with a lot of cervical incompetence if they're still desiring pregnancy. So those are the things we have to be wary about as we roll out this algorithm. Next one. So this is a new one, which basically has put together algorithm 5, algorithm 2, and 7. And this is the one that the National Department of Health seems to be running with. And I'll just, I hope it projects well. I think the colors are not so good. So basically, we are saying that any woman that qualifies would have this screening with HPV, and the sample is sent to the lab. And the lab, once they pick up that you are HPV positive, You as a clinician, being a nurse or a doctor, you don't have to do anything. The lab will automatically do what we call reflex cytology on your left. So if you are HPV negative, nothing to be done. We call you back 3 to 5 years, as we've already spoken about that. But if you are positive, the lab will automatically do cytology for you. If your cytology on your left again is normal, we will see you in about a year's time with an HPV test, basically trying to check have you cleared the infection. And that is important, that every woman should be able to clear. If it persists, obviously, then we want to pay more attention to that. If on the other side, your cytology comes back abnormal, your red, if it comes back with CIN2 or 3, we will not interfere with the old guidelines. All high cells will be treated with less, and these women will be followed up again in a year's time to see whether they have cleared. If on the other hand, you have CIN1 or ASCAS, that will be in your yellow, and these are people now who we don't want to overtreat, we can then avail them to thermal ablation or local ablative therapy. Again, we mentioned that these women should, you should be able to see the entire lesion. You should not occupy the whole of the ectocervix. Within the endocervix, you should be able to get to the upper margin of the transformation zone. So this is where the government, we are likely to go. Some provinces have adopted this, and others are also likely to follow suit. The challenge with the provinces that haven't followed is at that point where it says reflex cytology, because it means dual testing for all the people that are HPV positive. The good thing here is that I will show you the results, that in the pilot that we did, we are able to get rid of about 60% of women that are HPV negative, which means only 40% will end up on the left. So it's not quite a huge cost, because we are not doing dual testing for everybody. It's only dual testing for the 40% of those that we have tested HPV positive. I hope everybody is following. All right, thanks. Also, next one. So I kept mentioning the word triage or triage, whichever way you want to follow it, but it's appearing almost everywhere in the guidelines. The reason why we have to marry HPV with some form of triage is that we are going to end up over-treating if we go straight into just on the basis of being HPV positive. And I think that's the message we need to get even to our patients, to say, by having HPV, being HPV high risk positive, you do not necessarily have the abnormality. We have to perform another test that will now tell us, do we need to treat you or do we not need to treat you? So we need to remember at the back of our minds, what form of triage are we using? I mentioned in the previous algorithm that we are using cytology as our form of triage. We could also be using VIA as our triage form. Next. So yeah, why we need to is because cytology has a good sensitivity for high cell and CA, but the other forms of screening, it does not necessarily have the same sensitivity. So if your primary mode of screening was cytology like before, then we could use HPV as triage. But right now we've got it the other way around, where now our entry point is HPV and our triage is either going to be cytology or VIA. Very unlikely that we will end up ever using colposcopy as our triage. There are other modalities in the horizon, HPV genotyping, further genotyping such as MNRA or else E6, E7, and all the other molecular testing that can be done. Next one. Yeah, these are just the triage methods, as we mentioned. Next one also. Just again, emphasizing that With the introduction of HPV, the WHO itself recognizes that we must triage. It's appearing in all their algorithms. So far, I think the take-home message for us is that we are using cytology. It may be VIA in some settings, depending on the cost, but we favor VIA. We favor cytology as the national from the National Department of Health and some provinces. Next one. So just sharing the results of the CESTA study, I said it was sponsored by IARC, which is the International Agency of Research in Cancer. It's a subsidiary of WHO. So basically, they wanted to test these algorithms that we are now talking about. And those would be where we just apply acetic acid and treat. Or alternatively, we actually go through the VI steps to identify women that need to be treated. Next. So basically the objective was to determine the proportion of women, and with CESTA, the one we did at Wentworth, it was women living with HIV, but CESTA is an multinational study also being implemented in East London, Senegal, and other parts of Africa. That's why it says Africa here. But the proportion, the women that are being tested in other areas are not necessarily women living with HIV. We focused on the women living with HIV. Next slide. Next slide again. Yeah. So in that study, basically we were trying to test, can we identify the high grade lesions by just looking, and this is the VIA triage compared to just when the nurse would apply, and this was carried out by nurses, just acetic acid without. Colposcopy was only referred if the nurse felt that the patient's lesion was much more broader, or they couldn't exclude malignancy, or they couldn't see the upper lesion. So you can see in that study of women living with HIV, we screened about 400 of them. We picked up about 60% of them, 61% were HPV positive. This is quite high. Earlier on, I told you that we're looking at about 40% of women being HPV positive. Obviously, we know, those of you that follow HIV studies, that women living with HIV have got more high-risk subtypes, multiple subtypes at any one point in time. In that study, we found 60%. Out of interest, you'll see that women who, so we did both self-testing as well as clinician tested, and there was a much higher pickup rate with the self-testing where women inserted the tampon and then we sent it off. So that's, I think, one of the things that is being looked at is whether or not women can actually, or we can implement self-testing. In that study, it was quite higher pickup. So just coming back to the triage arm, so you see that when you applied acetic acid, 80% of them, of women who were HPV positive, ended up being VIA positive. So it wasn't a good discriminator. So by virtue of you being HPV positive, 80% already were VIA positive. Therefore, we are unable to separate those that had the lesion or did not have the lesion. A significant number, about 40% in the triage arm and about 35% in the non-triage arm, did not qualify to be treated with ablative therapy. So again, it tells you that, and this is, again, remember, these are women living with HIV. It might be different for women not living with HIV, that VIA is possible for them at a much higher rate. Whereas here, 8 out of 1, which is about 40%, ended up needing colposcopy, as you can see the arrow going down. Yeah, so, and then at 1 year, we shall come back to, yeah, we can continue. Next slide. So in this result of these women, we said 60% overall being HPV positive. The pickup rate was higher with self-testing. They were higher, in terms of HPV 16 or 18, it was very comparable. and with the treatment arms, it wasn't different as well in terms of those that were referred to colposcopy. Next slide. This slide again just shows the pickup rate between the self-test and the clinician tested. Next slide. So remember that we are talking about VIA being a triage, which is what WHO was trying to test. Remember, we are likely to not use VIA, we are likely to be using cytology, and I think some provinces have started. So we said that the sensitivity was not so good, in that 80% of women who already had HPV ended up needing to be treated anyway. We were unable to evaluate about 30 to 40%, depending on which arm the women fell in. But of those that ended up with colposcopy, we are able to pick up 40%. So if we treated, what this slide means is that if we treated women on the basis of being HPV positive and VIA positive, we were only going to correctly treat 40%, which means there was there would have been a 60% over treatment rate, because only those 40% would have had a CIN that would, according to the old algorithm, have needed to be treated. Yeah, the rest of the slide is similar to what I've just said. Next one. So in terms of performance, I spoke about various algorithms. Where we triage is algorithm 5, and the one that I referred to as the one that is being promoted by the HPV board, where you subtype according to the HPV genotype. You find that they perform very similarly. So whether we adopt as a country algorithm 4, which is subtyping according to 16, 18, and 45, or we adopt VIA as a triage, remember that we have introduced cytology. In that one, we were looking at VIA. We are not losing much because their sensitivities are similar, 91 and 88% positive, very comparable positive predictive value, and also specificity for CIN2, very similar as well. So none of these, when they compared neck to neck to the algorithm 4 of subtyping HPV versus subtyping through the VIA, they had the similar result. This was a mathematical model based on the patients that we had screened in CESTA. Next slide. So these women that we then treated in CESTA, they either had colposcopy and less, and I showed you the proportions, about 40%. And those that were CIN that had no abnormality, according to the VIA, they did not receive any treatment. And those that had abnormalities, according to the VIA, they ended up being treated with thermal ablation. So if you look at a year's review, where you now do HPV and you want to test them again to see which of the methods of treatment was more effective, you found that the recurrence or persistence of HPV was similar or comparable. Those that were not treated because their VIA was negative, they still had the lesions, about 46% of those, they still had the HPV. Those that were treated, 42%, they had thermal ablation, they still had the HPV. Those that had lead or cone biopsy, 38%. So basically, none of these was significant in terms of the differences. Whether you end up, I think this slide is basically to reassure us that with thermal ablation, particularly when applied to women of low-grade lesions, we are likely not to undertreat. If anything, it's comparable to our gold standard, which is our lead. Thanks. Next slide. So basically, I think the message, as I've said, high rate amongst these women carrying HPV because they are living with HIV. VIA in this group of women was a poor discriminator, and we would end up over treating about 60% of women with who do not have CIN 2 or above. Thanks. Next one. So I just want to also just look at what the DOH has done in the meantime while we're preparing as a country to screen with HPV. So it did a pilot Yeah, you can stay on this one. At 3 sites in the country, Gauteng, ILCH is KZN, and Kabeja was Eastern Cape. And this is where basically these were called according to where the lab was based. These are the types of machinery that they were using to test for HPV. They did close to 100,000 of these HPV tests according to the proportions you see there. And these are the subtypes that were treated according to the batches that were used. Next slide. So in this testing, as we mentioned, that women would get HPV test, and then they would, if they're HPV positive, there would be a reflex cytology. And in this group, large group of women that were tested, the HPV positivity was about 40%. The study that I mentioned, women living with HIV, we said 60%. But in general, the women that were tested, the prevalence of HPV was 40% higher as HPV. Next. And for this, I just want us to remember, because people are saying we're going to inundate the system with, if we doing a whole lot of HPV tests, particularly dual testing. Now remember, if you have 40% prevalence, only the 40% will then move forward to cytology, meaning that the 60% will fall away because they are HPV negative. So it is only the 40% that will then go forward to be tested with cytology. And you can see here that the ones that will be high cell Agas or malignant, the bottom 3, obviously these ones would get less. And therefore, the people that we really need to pay attention to in terms of whether we are going to do a VIA or we are going to do ablation will be the ASCAS and the low cell. That would be about 20%. Next. So again, just looking at the prevalence depending on the HIV status of the women. Again, women with HIV tend to have higher regardless of what lesion you have, including whether the cells were unsuitable or not, whether it's low grade or high grade. They tend to carry more HPV subtypes and have multiple subtypes at the same time. Next. Just coming a small word on thermal ablation, I think as we are likely to adopt this as a country, it has been found to be comparable to cryotherapy. In the study we mentioned, we did do both cryo and thermal ablation. Our nurses found cryo to be more tedious to do, in that you have to do it over about 5 to 10 minutes. You freeze and then you defrost, then you freeze again. The patient sometimes will be up on hold, so it's not so much user-friendly as opposed to thermal ablation. Thermal ablation is this device on your left. It comes in a little laptop case, very portable, as opposed to cryo, where you need a big cylinder of nitrous oxide and so forth. You need to refill the cylinder and so forth. So it's not so user-friendly, the cryotherapy. Thermal ablation, you charge, and the bottom here would be your battery, which you can charge overnight, and then you apply your device. The device comes with these probes, and we hope that by the time we implement, we will have the probe on the right. As you can see, it's got a little tip able to get into the cervix, as opposed to the one that is flat on your left, which just applies on the outside. WHO, it takes about 45 minutes. So you just apply. Basically, the woman is under no analgesia. You can apply analgesia afterwards, maybe give her some NSAID or Panado. You apply for about 45 minutes, and you should apply another one. The cure rates were better with a double application as opposed to a single application. And then you can reassure the woman thereafter. Very simple to implement, can be used by nurses as well, as we did in that study. Next slide. So just in summary, at the end, just to say that we are likely, and most provinces should be on that algorithm that uses cytology as our triage. As I mentioned, if we do that, because we have a 40% estimated as our prevalence, which means that the people that will have dual testing are the ones that, so we've gotten rid of the 60%, we are left with the 40%. And when you look at ablative therapy, it will be this group, which is just your 20% of the 40%. So just a small group that we will leave in the hands of every clinician. Everything else should go forward, which is your highest bill, your ASK-H, your AGAS malignancy, that is the one in the yellow, that stays the same as according to the previous. They move forward to colposcopy, plus or minus lab as the form of treatment and the preferred form of treatment. We should be getting ourselves as a country to look at this group of 20% of the people tested with cytology. So now teach the health workers on VIA as well as thermal ablation. I heard from the Department of Health that they are planning to roll out the thermal ablation devices, very easy to use, very easy to recharge, and also very tolerable for the from the patient's point of view. Next slide. I think we are at the end, despite all the struggles we've had for this presentation.
Yeah, thank you very much, Prof. Tsidi. This was a really great summary of everything we have discussed in terms of secondary prevention in the last 6 sessions. Thank you so much for really simplifying it and really bringing us on board in terms of what's happening with the CESTA study. We will open up for questions. Let me leave it to the colleagues first. I also have a 1 or 2 burning ones. I'll start first with the question, what age should we screen HPV using LBC? At what age should we screen HPV using LBC?
I don't know whether they mean HPV. Okay, let me ignore the question, but just answer. So when we're doing HPV, which is collected in an LBC bottle right now, we are starting at the age of 25 for women living with HIV, but we're also using 30 for women of unknown status or women that are negative as according to the OMS. So we haven't changed. For women living with HIV at diagnosis or else at the age of 25. If you want to test, for example, if you have a woman living with HIV who is 18, because we do have such, better use LBC. So write on your form cytology. Reason being that you already know that they are likely to have HPV and have multiple subtypes. So women younger than 25, if you want to test them for any reason, use cytology. But women above the age of 25, living with HIV, we are starting with HPV. And as we said, the lab will, by reflex, do cytology in most provinces. The forms are still to be adjusted according to NHLS. There is no place where you sign for HPV. And therefore, please, if you are using the government NHLS system at this point in time, we are using HPV, write it with your pen. They will, because they can't, if you don't write HPV, they will automatically only do cytology because that's what you ticked on the form. They will not do a test that has not been written. So for all intents and purposes right now, if you are requesting an HPV test, please write it with your pen until the forms have been adjusted. Yeah.
Thank you very much for that, Prof. I do understand that in the different provinces, the rollout of HPV testing is being managed very carefully. It is starting off in certain districts that have been identified. So colleagues that are joining from different provinces, please align yourself with what are the plans in your province. I will make an example. If you are in the Free State, it's probably 2 districts that are going to have access to HPV testing first, then other districts will follow. So colleagues, please align yourself to the plan in your province so that you don't have a lot of people that you've tested with HPV. Now you need them to send them for colposcopy, and now you don't know where to send them, or the services cannot cope with it. So please put this discussion in context of what is available in your province and what the rollout is.
Yes.
Second question, when are we expecting to implement the thermal ablation in South Africa?
So when you look at the guideline, back in the old guidelines, I think of 2019, already they had thermal ablation as a provision where it exists. So if you have the device, the ability, you do not even need to go through ethics and all that is in the guidelines. The updated guidelines also reinforce thermal ablation where it exists. So the centers of excellence right now that we know, we have started in KZN. We've got about 3 nurses trained. We have, I know Western Cape under Prof. Lindeni had already started long ago. There might be with Prof. Greta in Pretoria, Dr. Ndumi in Eastern Cape is doing SASA as well, so she's got a team as well. So we have availed ourselves to the Department of Health. They are aware of the skills that exist, and they will be coming to us as soon as they are ready. I think the last I spoke to Dr. Mulomo was that he's in the process of acquiring the devices. So yeah, the expertise are scarce, but the will is there, and really I think the Department of Health wants to move in that direction. Yeah.
Absolutely, Prof. And to add to that, the Department of Health is right now engaged in workshops, and they are planning to do workshops in all the provinces where colleagues or clinicians are going to be upscaled to be able to do colposcopy and to read the results properly. We will also be upscaled in terms of doing LEDs and also the thermal ablation. So colleagues, for those who are in the public sector, in the Free State, it happened recently. In the Eastern Cape, the workshop, a 3-day workshop happened in August with even a practical component. And in Mpumalanga, there's a workshop happening next week. So if it hasn't happened in your province, it is coming. And the plan is to ensure that LEDs is not just a procedure that is done in the tertiary and the regional hospitals, but it should be scaled down, or it should be brought down to the district level. So the plans are afoot. So just keep an eye out. If you are interested in this space, make sure that you attend when those workshops are being held in your province. There's a comment. Yes, please make the talk available to us. The confirmation was 7 p.m. and I was sent a meeting to invite at this time too. So a lot of us missed the talk. Colleagues, our sincerest apologies. There was a time change. I don't know if I'm saying it right, but the time in Geneva, where our head office is, the time changed on Sunday. So now Geneva is, I think, an hour earlier, and our webinar was set. So colleagues, please, we apologize for that, but we will make sure that everyone has access to the recording. At the beginning of the session, I did announce that everyone who's registered and has ever registered in the last 6 webinars will actually receive a link to the full presentations, all 7 presentations. Our apologies for that, but we will make up for it. We will make sure you receive the recordings. The next one, I'm happy to hear that cytology is part of the reflex or triage, having done cytology for 40+ years, and I know that the cytologists are dedicated to their job. and always put the patient first. This was a comment, Prof.
No problem. Yeah, no, we thought as a country that we would have an existing infrastructure. And if we really want to run and eliminate cervical cancer, we can't just drop it and run with things that we still have to train people. Remember, if we are choosing VIA, we still have to train people. Whereas we already have trained cytologists, we already have the infrastructure. So yeah, they are not about to become extinct not in the near future. Yeah.
Yeah. Thank you, Prof. Next question. If you find CIN2 or 3 on histology results, on histology results after LEDs, when would you review the patient for cytology again? And what should be done if it is persistent CIN2 or 3?
So if you remember, according to the old guidelines, if you did a LED and you sent for histology and the patient was supposed to come back 6 months later for repeat cytology to see whether or not your treatment has worked, or else the lesion is persistent, looking at margins and all the like. With the new, you'll see that with that algorithm, we said everybody is going to be reviewed in 1 year. So that part, I think, for the high cell who are being treated with the LEDs, we will keep them with the old algorithm. As I said, there's still a lot of fluidity with the guidelines. So I would say anywhere between 6 to 12 months, but definitely by 12 months, that patient should be reviewed with cytology, not with HPV. Remember that when you review, you are reviewing with the last lesion that you saw. If the last thing you picked up was HPV, so for the people that were positive and had no cytological abnormalities, you will repeat HPV. But the ones that had abnormalities, you go back to the last abnormality you found, which is your cytology, then you do cytology because you treated them. So if you still find persistent CIN2, you should either repeat the LEDs, just like we've repeated LEDs before. Alternatively, the woman, if she's not desirous of fertility, either you go on to, LEDs or cone. If not desirous of fertility, you can move on to a hysterectomy.
Right.
Yeah.
Thank you very much, Prof. Okay, let me see if there's anything.
There's something about how can we find out about the workshops.
Okay, colleagues, the workshops are the series is concluded for now. If there is anything that comes up on the plan to do more webinars or to do CMEs, for the people who have registered, we will share the information. We will invite you, as we have been inviting you throughout the week. If you remember, the first time you joined, you heard it from social media or wherever, but then after we got your details, we would always send you a link to the recording after the webinar, and we would invite you. So now that we have your details, colleagues, if there is an opportunity, we get more webinars or we are going to do face-to-face, we will invite you through the email as we have been doing. In addition, we will also put up invitations as we've been doing on LinkedIn, on Facebook. Social media is the thing. So it will be on the Find, we will put it on the Find platforms, but you will also see it on my personal social media platforms as well. So you will not miss out, colleagues. We will use the email addresses that we have. Thank you for that.
Yeah. I think the question might also be speaking about the workshops that are provincial that the government, the DOH is running. I think those, the NDOH is basically aiming at the health workers within the public sector, and also the ones that are working in women's MWCH, maternal and women's healthcare. So those are the targeted people when it comes to provincial workshops. And these workshops are very similar to what Dr. Nzi has been running with the past 7. So they are more informative, didactic, and so forth. When it comes to colposcopy, VIA, and thermal ablation, those are hands-on, and they might need much more intense workshops, and also a targeted group of people per province, still to be identified, obviously, when that one rolls out. Right now, the 3-day workshop that the DOH is running is more the didactic lectures, just to put everybody on the same page in terms of what do we mean when we say high-risk HPV rollout, and what follows thereafter. Thanks.
Yes. Thank you very much, Prof. And I'm assuming the invitations for those will come through the usual DOH channels. It will come through the districts into the facilities, and people, the relevant people will be nominated to go to them. For colleagues in the private sector, my answer before would apply, because then you probably won't have we won't have the opportunity to join the NDOH at this point, maybe later. But colleagues, as I said, we will put whatever is available for everyone on the different platforms. And I also have to add, colleagues, that if you want to get into a formalized course, you can also access the Knowledge Hub of the Department of Health. There is a sexual and reproductive health module, sexual and reproductive health training. And in that training, you can actually select if you just want to go to the cervical cancer module, and you can do that module and, do it at your own pace and go through the content in much more detail at your own pace. So that is what is available at this point, colleagues. I am going back, Prof. Tsidi, to another question that we had from a colleague. I think it was posed last week, but we didn't have an opportunity. Let me ask on behalf of the colleague, what your experience is with HPV negative cervical abnormalities, dysplasias, and invasive lesions.
I don't have much experience in terms of that, but we know that, as we said, most of the abnormalities, whether there's cancer at the end or they are pre-malignant lesions, are ascribable to some form of HPV. So we do recognize that there is cervical cancer, particularly adeno-CA, that may not, remember that the common one is squamous CA. Adeno-CA, there might be a few or the atypical types, the serous types or whatever, that may not be attributable to HPV, but those are very, very little. And hence why when we do HPV testing, we do not necessarily pay much attention, very, very little in terms of proportion of cancer that is not attributable to HPV. I hope that answers, yeah.
Okay, yeah, no, thank you very much, Prof. Prof, I also have a question. When you were presenting the WHO algorithms, I think it was algorithm 2 or 7, I can't remember, but at the top, it was saying HPV DNA testing. That was the first screening test. Then it would say triage. But on those algorithms, it seemed to me like it was not specific when there were positive findings. It was not specific that it was 16, 18, or any other. So I just want to check with you, in our case, where our tests are able to actually genotype, we get the genotype that this is 16 or 18. Is it still necessary to go to cytology when you know that someone has HPV 16? And what is the risk of progressing to cancer for those types of patients with HPV 16? Is it still,
Yeah.
I don't know, I found it gave me a little bit of concern and discomfort that I already know it's 16, the most high risk, and I'm still taking them to cytology where I could maybe miss, where cytology is not 100% sensitive.
Yeah, so basically, if you remember that I said that the HPV board favors one of those algorithms that subtypes according to the genotype and flags out 16, 18, 35 plus or minus 45 in our setting. So, but we are not moving in that direction. The reason is when you have a program that you want to roll out to the masses, our nurses, everybody on the ground. Remember, cervical cancer, in order for us to win the 90, 70, 90, we've really got to reach out as wide as we can. Now, you've got to come up with the most simple algorithm that will not confuse the dumbest of us, including me. You understand? So if you are going to say you are age 40, you are age 45, if you are going to say you carry 16, you carry what, then we're going to confuse people. We just want people to understand when we say you are high risk positive, we've identified any of those subtypes between of the 14 to 16 types that are called high risk. Of course, if you have the ability, then we would tease it out in terms of your age. The thing that we want to pay attention to right now is, are you HIV positive? Because HIV positive women, without doubt, they present and respond differently. I hear the argument about 16 and 18, but remember 16 and 18, yes, it does lead to cancer, but this is a woman under your care. So whether I treat her with LEDs or I treat her with ablation therapy, I'm still gonna see her hopefully in a year's time. So yeah, you will remember that, yes, there was one algorithm that the WHO says you can tease out or triage according to the subtype. And it is the one that was favored by the HPV board. But at the national level, we thought it would just cause a lot of confusion because, again, the machinery is not the same. In one province, they're using Abbott or whoever who will be able to say 16, 18 or whatever, and actually group them together. There are discussions, even with the lab devices, to say, can you group for us differently, 16, 18, 35, the ones that we worry about in the country, put them in one batch. Then in another batch, we can put the other subtypes of the 14. So there are moves in terms of those type of discussions. In the near future, we may change our guidelines based on the genotyping, but at the moment, we're trying to get everyone on board as fast as we possibly could. Yeah.
Thank you very much, Prof. I'm looking at the Q&A and I see that it is quiet. So I'm going to request colleagues if they have any questions. This is your time. Going once, going twice.
If I can come in, Dr.
Yes.
There was a query about, you know, how come when we test, we always talking about 16 and 18 and yet people are seeing a large number of other subtypes. And I hope that that message came out clear in the slide to say it depends where you are looking. If you're looking at cancer, the leading subtypes are 16 and 18, and they lead right through, particularly 16 in our setting. But when you look at lower lesions, ASCA, CIN1, the other subtypes are featuring. So most people who are testing, which is a lot of, I suppose, the people on this platform, when you're testing women who are precancerous, that is why you are seeing other subtypes much more than the other 16 and 18, because these are precancerous lesions. I hope that came out clear.
Yes, Prof. Wow, that clarifies it very well. Now, in the absence of questions, Prof, are you happy to deal with the last two on vaccines before I do a wrap up?
Yeah, so
There was, yes,
yeah, they were looking for a vaccine that covers 35,
35.
yeah. So when you look at N9, Gardasil 9, sorry, it does have those subtypes included. I think 35 is the one that is missing, but what's that company called? MSD is aware of that. But that's the reason why. And remember that much as a particular subtype may not be in the vaccine, we now have Gardasil as we know it, which has 4 subtypes, and then Gardasil 9 has got 9 subtypes, and one of them missing 35. There is cross coverage of each subtype. So much as yes, 35 may not be there, or another subtype that we deem as high risk, there is cross coverage of the different subtypes in the vaccine, the current vaccines that we, yeah.
Aha. Thank you very much, Prof. Oh, there's a question. What is the comparative complication profile of thermal ablation versus cryotherapy?
Both of them, there's a bit of cramps, very unlikely to give you menstrual abnormalities. There is no excision of the cervix as compared to LETs. So it's basically just some form of discharge and cramps in the next 48 hours or something like that. Very well tolerable, both of them. The only challenge is that the other one you've got to procure or administer over 10 minutes. The other one is basically 2 minutes, 45 seconds times 2. So both are very comparable. As I mentioned, cryotherapy is a little cumbersome, not just for the nurse or whoever is administering it, but also for the patient who's up on poles at that point. So that's why thermal ablation is being favored. LETs, as we know, there's excision, there's bleeding, you have removed the tissue, and all of that. But it still remains the advantage in a sense that you've got histology to confirm, as opposed to the other one, the ablative, whether cryo or thermal, you do not have tissue for confirmation.
Absolutely. Thank you very much, Prof. Prof, that was amazing. We really thank you for making the time. We have learned a lot, and you have cemented a lot of what we've been discussing in the past 6 webinars. I'm hearing it clearer and clearer, and I hope that the colleagues also have heard it very well. Colleagues, I'm going to wrap up this session with just a short overview of the journey we have taken together and some of the key learnings. According to me, we get different things from our attendance, but I'll just share some of the key things that I picked up, was a few aha moments there and there, and then we can conclude. Colleagues, I'm taking you back to our very first webinar when we were joined by Dr. Giose, who is a gynae oncologist in the Eastern Cape. She brought in an overview. She came to present to us an overview of cervical cancer, just like touching on every topic, just to highlight where we should be or where we should be going in the next 7 webinars. Colleagues, what stood out for me in her talk was when she said the vagina is a holy passage, and we shouldn't be scared to talk about it, and we shouldn't be scared of it, and we shouldn't be scared to examine it. She also said it is the very same passage that brought forth the Lord Jesus, and Nelson Mandela came through it. So we need not be embarrassed about it. I remember also she was lamenting about, she talked about self-sampling just a little bit, but then she lamented the fact that self-sampling should not be a method for us to avoid examining the lower genital area and to avoid examining the vagina. She was still cervix. She was still saying to us, even though we are going to be self-sampling, we've heard a lot about it, we still need to ensure that we look at the lower genital area, remembering that there's also vulval lesions that can develop, vaginal lesions. So colleagues, for me, that was some of the one of the key things that stood out from that talk. We also then went into the second webinar with Dr. Mandondo, a gynecologist from the Eastern Cape, and she gave us some insight from the work that they do in the Eastern Cape and where they are in terms of rolling out the mother-daughter campaign. She also introduced self-sampling again to us, and importantly, she shared some statistics from the Eastern Cape Cancer Registry. And again, what stood out for me there was when she said, you know, the distribution of cervical cancer. Cervical cancer doesn't only happen to HIV positive patients, but she told us that when they looked at the data from 2012 to 2001, 39.4% of their cervical cancer diagnosed cancer cases were HIV positive, 39.4%. 35.1% were HIV negative, and 25.5% were of unknown HIV status. She was emphasizing that we shouldn't just focus screening efforts to the HIV positive population only, but we should screen everybody. She also presented data that showed that many of their clients, about just over 50%, I think it was around 54% of the clients that they are seeing with cervical cancer actually come in rather at advanced stages. And she was showing that the prevalent stage of presentation is stage 3B, when the disease has spread to the pelvic wall or the lower third of the vagina. So colleagues, that was just a little bit about the session with Dr. Mandondo. And she also showed us some of the materials that that has been developed with partners like us, Find, and another partner, Chai, that they are using, the material that they are using to create awareness amongst the staff and amongst the patients. She showed us some pamphlets and some posters as well. In the third webinar, we had Dr. Maharaj, who is also a gynae oncologist from Inkosi Albert Luthuli Central Hospital. She unpacked the HPV genotypes for us, took us through what is high-risk HPV, what are high-risk HPV genotypes, what are low-risk HPV genotypes, and also, you know, presented to us what are the diseases that are associated with the different genotypes. The fourth webinar, we were joined by Dr. Carter and Dr. Meyer from UNICEF. Dr. Carter is a gynecologist in Johannesburg, and she spoke to us about HPV vaccination, broke down the rationale for the single dose vaccination. We had interesting discussions around why boys are not getting vaccinated, and there was a very strong advocacy from participants that boys should not be left behind. So we went into details of HPV vaccination. Ms. Meyer from UNICEF also spoke to us about their work around factors, the research that they have done, looking at factors that contribute to vaccine hesitancy. And one of the key take-homes for me, colleagues, was when she shared that healthcare workers are actually very influential in the decisions taken by parents, whether they should vaccinate their children or not. And she also highlighted the influence of teachers as well in the vaccine being accepted. But it always stood out to me that the healthcare worker is so important in ensuring that the vaccine is acceptable. And she showed us some of the reasons why people don't want to vaccinate, including worries about adverse events. So colleagues, that was a very nice session as well. And we had a lot of discussions around the HPV vaccine. In webinar 5, we were joined by Dr. Sebitloane from KZN, who is a gynecologist in private practice, and she spoke to us about HPV testing, and that's when we really now unpacked HPV self-sampling. We showed, we demonstrated the devices that are available. I remember us seeing a video of the Evelyn brush. We also, and how that is used for sample self-collection. We also discussed the flock swab and how that is used. We also showed the tampon that is used by a small lab in the Gauteng area. And we spoke about all those devices and how they can be used to improve screening amongst our clients. And their utility is primarily for HPV testing. Colleagues, we then move on to webinar 6, where we were joined by Dr. Trudy Smith, who is a gynae oncologist who's working in Gauteng. We spoke a lot about secondary prevention and the gadgets that are, or the methods that we can use to treat cancer, precancerous lesions. She spoke about LEDs. Then she also spoke about the ablative treatments at length, the ablative treatments being the cryotherapy and the thermal ablation. One of the comments that she made that stuck with me was that HPV is ubiquitous, and if you really want to prevent HPV, you need to wrap yourself in a giant condom and just tie it at the end, because it is so easy to actually get infection with HPV. And colleagues, today we are wrapping up with Prof. Tsidi, and she has taken us, we've been seeing the algorithms throughout the presentations. But colleagues, today, Prof. Tsidi, thank you so much for your input. We just needed to get a little bit inside and behind the algorithms to say what influenced these algorithms. Why is this line saying triage? Why is this line saying if this, do that? So thank you very much, Prof, for sharing this with us. I am confident, I am really confident that colleagues have left this webinar series better than they were before, with more knowledge, more information. And if there were any cavities in our knowledge, the cavities are filled with useful information that we are going to use at our practices, in our, whether we are in private practice or public, we are working for the public, we are going to ensure that we implement with understanding and with also a view of why we are doing this. I'm getting to the 90, 70, 90 targets that we really, this is one cancer that we can eliminate. It is a kind, someone said it's a kind cancer. I think it was one of the colleagues from Department of Health, yes, one of the colleagues said, this is a kind cancer because we know exactly what is the causative organism for the majority of cases, HPV. This organism doesn't just come in and cause havoc. We have time in which we can actually pick up that there is a problem. So the pathogenesis, we are looking at a very long period during which we can screen and find patients with precancerous lesions and actually treat them effectively, cure them of the infection. So colleagues, with that, I would like to say thank you very much for joining us in this webinar series. We will keep you updated if there is anything similar that is going on. And for the colleagues that are in the Department of Health that are working in the public sector, be on the lookout. You will see there's going to be a lot of activity. Please don't be left out. And for all of us as healthcare workers, colleagues, I am hoping we are all now confident enough to be able to raise our hand and say, wherever we are, if it's a church, I'll start with church because I spend a lot of time there. If it's a church and they want a talk, you will be able to talk about cervical cancer and its prevention. If you are in a whatever environment you are in communities, gatherings, or if there are events and you are being called to share something about cervical cancer, I'm hoping, colleagues, that we will be able to do that because we are now equipped with the right information and we have the right tools. We know exactly where to go for more information. We have a whole library of webinars that you can refer to at any point. We have the Department of Health website with the Knowledge Hub that you can go into to look for information. Colleagues, before I turn into a preacher, I think we should leave it here. If there are any comments, we just have, we have 10 minutes in which we can take any comments. And if anyone wants to say something, Lamia is here, my colleague from FIND. Please assist us with the unmuting of colleagues. Let me give you the floor, colleagues. You've heard enough of us. Let's hear if there are any comments. Oh, I see Nkosi made a comment. Thank you, Dr. Ausi, for the wrap up. We really appreciate it. It is my pleasure. Dinada, don't mention it. There is a raised hand, Lamia. There was a raised hand. Or even if you type it on the comments, colleagues, I know some people, we don't like to talk much since the era of, the technology. Oh, yes, here are some comments. Okay, how could I deny us like this? Dr. Prof. Sebitloane, all the sessions were very informative. Thank you. Pleasure. With such informative sessions, we could have decreased numbers of cervical cancer. Thank you, Prof. I concur. We are going to reduce cervical cancer. Thank you. It was worth it. Thank you. It has been informative. Thank you very much. As a clinical nurse manager, I found all sessions very informative with recent research studies. Thank you for the presentation. Thank you so much, colleague. Very informative, highly informative session. Thank you, Prof. Thank you so much for the webinars, Dr. Nkri and FIND. Thank you, colleagues. Of course, we cannot forget to thank FIND for making this possible. Thank you so much, colleagues. I see it was very informative, comprehensive sessions. Thank you very much from Malawi. I enjoyed the discussions. Thank you so much for joining us, colleagues. It's Halloween indeed, yeah? Ausi is not even aware that she was I don't know. Okay, more knowledge, more information. I'm a better obstetric and gynae practitioner. Colleagues, music to the ears. Thank you so much, colleagues. And thank you. I want to particularly thank the obstetric and gynae specialists for joining, because I know we are in good hands. When specialists say, I will come and listen and learn more, then colleagues, what else can we ask for? Thank you, colleagues. I'm seeing the comments. It was informative. Yes, someone is a retired coordinator, but they found it informative. Yes. Oh, don't worry. Someone said they regret missing the previous sessions. You will get them on the link and you can listen. Do not worry, we've got you covered. Enjoyed it from Wheatbank. Awesome. Colleagues, thank you very much. With that, I want to again thank all the previous speakers in their absence. Thank you, colleagues, for making time. I want to thank FIND for making this possible. Thank you to the administrative team, Lamia, Carolina, everyone who was involved behind the scenes. Thank you so much, colleagues. You made everything seem so easy. Your efforts are really appreciated. Colleagues, with that, I bid you farewell till we meet again. It really has been amazing. Thank you very much, colleagues.
Well done, Dr. Ausi, for all the efforts that you put in and the running around with cervical cancer. We really, really appreciate this. And I believe that our numbers for screening will go up. And we will be in line to meet the 90, 70, 90 target. Bless you. And thank you so much.
Thank you, Prof.
Thanks
Thank
to
you.
all the participants and those who joined in. Yeah.
Thank you, colleagues. Thank you. All right. Thank you, colleagues. And it is a good night from me.